I think we talked a lot already about lutetium-PSMA to find disease, but we also can use lutetium-PSMA as sort of a radiologic biomarker to try and select patients in a theranostic paradigm. And we saw some great presidential data from Scott Tagawa. You want to walk us through PSMAddition?
Yeah, I mean, this was, again, highly obviously publicized as a presidential press release earlier from the PSMAddition trial. Look, I think our listeners and viewers know, but we have lutetium-PSMA 617 in a post-taxane setting per vision, so post-ARPI, post-chemo. There's the data in taxane-naive PSMA4, which as of this recording is highly discussed around the world for HTA process and ultimate use. But now this was looking at saying, hey, let's add, so addition of lutetium in the MCSPC setting. So these were patients allowing up to ECOG2 needed one PSMA metastatic lesion or more on gallium-68 type of imaging. They were appropriate to get ADT and ARPI. So we're not going to talk about triplets here because chemo wasn't really used. The patients were randomized 1-to-1 to that control arm of ADT and ARPI versus having ADT, ARPI, and then lutetium in the classic kind of schedule of 7.4 gigabecquerels plus or minus 10%, 6 cycles every 6 weeks, and then RPFS, primary endpoint, and allowing crossover, and then having a safety follow-up and OS. So we got a second interim RPFS readout presented here. And essentially what's interesting is that when you look at just the treatments people had at allocation, most patients were getting abiraterone. About a third were getting apalutamide, maybe just over a quarter were getting enza. Daro wasn't super high used in this setting, just given the time trial was conducted.